Hi, how are you? So I'm Hajime. No, I'm one of the organizers of this series. Today we have the Professor Donna Spiegelman. So Dr. Donna Spiegelman is the Susan Dwight Bliss Professor of Biostatistics at the Yale School of Medicine and Professor of Statistics and Data Science at Yale University. She is an direct both from Yale Center method implementation and prevention science, CMIPS, and the research method core within the Yale Center for Interdisciplinary Research on AIDS. And then Dr. Spiegelman also leads a global oncology program at the Yale Cancer Institute. So with a unique joint doctorate in biostatistics and epidemiology, our works are reached suffering. Our research focuses on emerging field of implementation science, aiming to overcome barriers to implementing evidence-based interventions in public health. At CMIPS, Dr. Spiegelman and her colleagues developed innovative statistical methods for implementation science, including the DAR as you go, WHGO design for adult. So with nearly 30 years of prior experience at our School of Public Health, she brings extensive expertise in biostatistics and epidemiology to her current role at Yale. So please join me in welcoming Professor Donna Spiegelman to share her insight and the latest research findings with us today. So we have honored to have her.
Pleasure to be back, and thanks Hajime and Svetlana for inviting me. I'm very happy to be here, and I think there's probably a number of people on Zoom as well, so welcome to those of you on Zoom. I think you can see this is going to be kind of a general overview of quantitative methods and implementation and prevention science, and I welcome questions and comments at any point during this talk, and so please don't be shy about that sort of. So I'll give a little bit of an introduction to implementation science in general. I know there's some people here like Hajime who knows quite a bit about it, and other people it might be kind of new. And then I'll talk about some of the quantitative methods and overview of kind of what already exists, and then also discuss some of the newer things that we're working on at our center. So we talk about the implementation pipeline and where does implementation science fit in? So I think a lot of the work going on here at the Dana-Farber and the Department of Biostat and CBAR and so forth is efficacy research, which involves establishing the efficacy or not of experimental drugs and devices, usually in the context of individually randomized clinical trials. And then the idea is for things that get where efficacy is established, we might go on to effectiveness and cost effectiveness research. Some of this might be going on here as well. Another term for effectiveness trials is sometimes pragmatic trials, and they tend to be community-based, much larger, much fewer exclusion criteria, engaging community-based providers, not necessarily academic providers, and so forth. And then the idea there is among those interventions that are found to be efficacious at this first phase, to what extent are they effective? And there's also often some kind of what's called a voltage drop where we see a stronger effect at the efficacy level. And then we go down to the community or population level, we sometimes see a drop in effectiveness, but that often tends to be the real world benefit of the given intervention or treatment. And then I added to this cost effectiveness, where in addition to establishing effectiveness on this more population level, we might also be interested in the cost of the intervention and the relative cost of some new intervention compared to, say, standard of care or some competing alternative. And then those, oftentimes it's been thought that once we establish effectiveness and cost effectiveness, that the world will just take up the intervention. But unfortunately, I see people smiling. I guess many people know that turns out to not be the case. And in fact, a famous saying in the implementation science world is that it takes 17 years for 14% of successful research to find its way into clinical and public health practice. So a majority of research just stays in the journals, stays on our CVs, but doesn't really make that translating move. So that's why implementation science has come into play as an important aspect of research at NIH and elsewhere. It's to try to address this gap of this translation and uptake and spread of evidence-based interventions into common practice. And so we're not about in implementation science, there's no discovery involved. We're working with evidence-based interventions. And what we're trying to do is develop programs that will make these interventions attractive to be taken up at a much wider scale and in many more contexts than where they were originally studied, and then to be delivered with fidelity so that they retain the benefit that's been shown to be effective and that they're sustained over time. And so those are the types of issues that are addressed in implementation science. And then finally, we have this term dissemination, which would be the last piece, and again is related to where implementation science might develop programs that should be much more scalable. Scaling, there's two terms for scale. There's scaling up and scaling out, where scale up means scaling up within the population in which effectiveness was already established, and then scaling it up to all those who are a part of that population rather than the smaller sample that was in the effectiveness trial. And then scaling out means scaling out to new contexts. And so dissemination looks at how to improve that scaling up and scaling out, and has become an important part. We used to, originally the terminology was implementation science or implementation research, and now say at NIH, there's a dissemination and implementation science study section, and the dissemination piece got added and is an important aspect of the research and the focus of attention now. So another thing that I like to call to everybody's attention about implementation science is that our studies should be rigorous, rapid, and relevant. Sometimes people call that the 3 R's. And here, in the Department of Biostatistics, rigorous is very important. And sometimes people think that efficacy trials are the most rigorous, and then effectiveness trials are less rigorous, and then that would mean implementation studies would not be rigorous at all. But I would like to contend that the opposite is true. And in fact, rigor is just as important at the effectiveness level and just as important at the implementation level. And in fact, in terms of the methodologic issues that come up, in my opinion, and I've worked at all 3 of these levels, they're much more challenging. The messier the studies are, the harder it is to control things, the more kinds of biases that can creep in, and so forth. The harder we have to work as methodologists to provide appropriate methods that can give valid causal estimates. So that's rigor. And then rapid, and you'll see in some of the examples, we're often studying, high impact public health questions. And policymakers really want to know the answers to these questions. And we have a habit as sort of academic researchers of kind of thinking, we take our time with our studies and we do them really carefully and make sure that, everything is done the way it should be according to the protocol. And we can take so much time, and I've been involved in several studies, which I'll give an example of a little later in the talk, where we took too long. The policymakers just made their decision, and our study wasn't even really that relevant anymore to the question that it was intended to address. So I think that this is an interesting area of research in how to increase the rapidity of these studies. I think both effectiveness trials as well as implementation trials without sacrificing the rigor. And I think maybe some of the answer does lie in the use of electronic health records for research, maybe integrating observational methods more into research, and so on. And then finally, relevant. I think maybe for us as biostatisticians, we probably kind of know this. We're generally not determining the questions. Other investigators, in terms of subject matter questions, other investigators will come to us and then we'll provide the best methodology for answering that question. And then this is just as true in implementation science, and then it starts to apply even to the investigators who are going to be, say, the PIs of these studies. The public health and clinical relevance of kind of looming questions is what decides what's going to be the objects of research, as opposed to what an individual researcher's interests are or what their kind of specialty is and so forth. So we don't run into the situation of the tail wagging the dog, so to speak. So what's different about implementation science studies? It's not like it's a whole other world. I mean, as some of you know, I worked in observational epidemiology for many, many years while I was here. I was also involved in kind of trials that were kind of often efficacy trials and sometimes effectiveness trials in a global health context. And I've since moved into primarily focusing on implementation research. And, how is it different? So as I was talking about with Hajime, one of the first things is that implementation science is very much a collaboration with a number of disciplines. So we're used to collaborating with clinical investigators and epidemiologists and or public health leaders as quantitative methodologists and statisticians. But now we've got two other professions that get added into the mix here. The first one is social scientists. So when I write here, implementation science is guided or even driven by theory, models, and frameworks. This is not like probability theory or the theory of statistical inference. What we're talking about here are these social science theories of behavioral change that have been developed by social scientists. And some very common ones are Reame, Seifer, Proctor's model of implementation outcomes, and so forth. And you'll find that if you're working on the design of an implementation study, it's absolutely essential to involve social scientists who have expertise in this realm of theory, models, and frameworks. And here at the Dana-Farber, you have somebody, a leader in this area, Karen Emmons. So she would be the person to go to. She knows this stuff inside and out. She knows all the social science people in the implementation science world who are doing this kind of work. But when I first started doing implementation science, when I was over at the School of Public Health, we didn't realize the importance of this social science aspect. And we sent in a number of grants that I thought were very good, but because these social science theories weren't embedded, and it's not just like one paragraph somewhere, it has to be really integrated into the entire project. They weren't getting funded. So that's one thing that's very different than what I'm used to. Another aspect is the interventions are complex. So it's not a matter of one drug versus another, one dose of calcium supplements versus another dose of calcium supplements. These are complex, multi-level, multi-component interventions. And on the multi-level, what's meant there, which I think we're somewhat familiar with in hierarchical models and so forth in statistics, is an intervention, a complex intervention bundle may involve components that hit at different levels. And those are believed to be probably the most powerful and successful packages. So implementation strategy bundle might involve making changes at the healthcare system, among policymakers, organizational leaders, healthcare providers, clients, and their families and social networks, not one or the other, but literally multiple components that are addressing all these different levels. Because again, what are we talking about? Adoption of evidence-based interventions, delivering them with fidelity. So it's not just about patients, are they taking their drug every day or not? It's like, are the materials there? Are the providers trained? Are they remembering to bring it up when they see their patients? Are people getting reminders? Are they being treated with dignity and respect? There are all these different factors that are involved. And to what extent some components are more important to than another is a very interesting and active area of implementation research. Then also, because of the complex nature, these interventions can be dynamic also, meaning that something needs to be done in the beginning, then that's over with. Then you're moving on to something that's happening kind of in the middle, and then maybe some things at the end. And if they're not being delivered at the right time, they might be ineffective. So we have to take that into account in the design of these intervention strategy bundles. And then finally, from the statistical study design point of view, these kinds of studies are almost always cluster randomized. Because when you think of the multi-level nature of this, the complexity of them, it's not really possible, say, in the same facility or village or hospital to give like people in one house one thing and then their next door neighbor something else. It's just not feasible. So we end up with almost always cluster randomized designs. And then there's lots of interesting statistical issues with cluster randomized designs. So now we'll talk about some of the study designs that come up in implementation science. So we have RCT, the individually randomized RCT, and then at least four other experimental designs that are in common practice in implementation science. And when I say experimental, it means that there's some element of randomization going on. So we have cluster randomized trials. That's what CRT stands for. SWD stands for step wedge designs. And then there's a MOST design that there's a lot of talk about in implementation science. I'm going to hopefully have time to go over that a little bit. And then there's the LOGO design that our group has worked on. So those are, and then you can also maybe add the SMART design, which you might have heard of. That's the design that's been popularized by Susan Murphy and her group. And it has some relevance to implementation science. But in my opinion, somewhat limited because of all of the challenges in randomization. A number of other designs are considered and used as well. So we have the class of what's called quasi-experimental designs. These were mainly popularized by health economists initially and other social scientists. So there's the pre-post design. There's the difference in difference design. There's the interrupted time series design and control interrupted time series design. And by the way, in terms of like biostatistics curriculum, it's really only design one that's taught to biostat students, masters and PhD students. Now I have heard when I've given this variation of this talk in other places, some biostat departments are talking about cluster randomized designs. I didn't learn that, but maybe some younger people have learned that in their biostat classes. But other than that, I mean, these other types of designs are not really covered. And I think with quasi-experimental, people who study health economics and in the economics world, they learn about these, and they've been the promoters of these designs. Although, things are crossing over and fertilizing, so now there's work in biostatistics on some of these designs. Then, as we have the observational designs, cohort, cross-sectional, case control. Those are the designs that arose out of epidemiology, purely observational. I think they're underutilized in implementation research, but kind of interestingly, they're sort of being rediscovered by implementation scientists. And now there's some articles about observational study designs and how they could be useful in implementation research, because it began from the culture where randomization was the thing to do. And so now people are starting to realize we can't randomize everything. And then finally, there's two other designs, hybrid designs and mixed methods designs that come up that I'll try to touch on. Yes?
I think in the chat, there is. The question is, some literature stepped wedge design is considered quasi-experimental. Could you use
Yeah, I hate when other people do this when I'm giving a talk, but I'm going to get to it when I get to step wedge designs. And I'll show you how it both has a quasi-experimental aspect as well as a randomized aspect when I get to that, I promise. So thank you. And if I forget, please remind me. We're getting to it soon. Also, maybe you can keep me informed on the time. So I just want to go over this quick. So implementation science should be pragmatic, whether you're doing a pragmatic trial or an implementation trial. So I just want to make people aware that there are these papers, and this one in particular, where if you're designing an implementation study, this is a way to systematically go through the features of your study to determine how pragmatic it is. And we have a tendency, I think, to design non-pragmatic trials because our orientation is really efficacy research. And it's very hard to pull away from that. But in this world, in this implementation research world, and even the pragmatic trial world, the advantages are to make these trials as pragmatic as possible on these different elements, such as exclusion criteria, missing data, who are all the things I had earlier mentioned, providers, but ways of quantifying that. So that's just to make you aware that it's kind of a concrete thing that can actually be measured and discussed. So the experimental study design. So I'll first talk about those a little bit. Randomized controlled trials, I'm actually not going to talk about because I assume everybody knows about them. Cluster randomized, I'll talk about a little, and then step wedge designs I'll talk about. So this is a schematic for a cluster randomized trial compared to a simple or individually randomized trial. So the main thing is, you kind of have the same number of people, but in an individually randomized trial, we flip the coin for each person, and then they're basically sorted into the intervention group bin or the control group bin. Then we have the cluster randomized trial where people might be grouped in villages and schools and hospitals by practices. And so they're coming within these circles. And what we do is we flip the coin on the circle, and then a lot of them either goes to the intervention group or the control group. So I'm going to give an example of a study I worked on. You can see the Harvard logo because I worked on it while I was at Harvard. Although we actually published the paper, migrated with me to Yale, and we published the paper when I was at Yale with one of our Yale PhD students leading some of the analysis. But this was the Familia Salama study. It was based in Dar es Salaam, Tanzania. I was working with Wafai Fauzi in the Global Health Department at the Harvard School of Public Health, and Till Barninghausen, who was also there and is now at the Heidelberg Institute for Public Health in Germany. And this is a 2x2 factorial cluster randomized trial. It's kind of a combination of an effectiveness and an implementation trial because one intervention was comparing standard of care for bringing pregnant women in for services during their pregnancy compared to enhanced community health worker intervention. And the idea here was, there's a large global disparity in maternal mortality. It's one of the biggest disparities in global health is maternal mortality. And the World Health Organization, which sets a lot of policy for these sorts of things, recommends that all pregnant women have at least 4 antenatal care visits before they deliver, and ideally even have one in their first trimester. And that's not something that is necessarily common practice at all in many places around the world. So we were trying to see if by providing enhanced community health worker support that we could get more pregnant women in to have 4 more ANC visits. And then that was crossed with what was called option A versus option B, which are 2 types of antiretroviral therapies for preventing the transmission of HIV from mother to child. So these were embedded into the study and took place at a very large scale in 2 of the 3 districts in Dar es Salaam, which is one of the largest cities in sub-Saharan Africa. So it was about 60 wards. And then you can see how we took the 60 wards when we first randomized them to community intervention versus to community health worker intervention versus standard of care, and then to option A versus option B. And just to get back to the option A versus option B issue, there were two regimens being considered. And at the time this study started, they were considered to be an equipoise in the sense that the World Health Organization said all countries should be doing one of these two, but given their own local conditions, they should decide which one to do. And like nobody knew. So we were going to try to answer that question about whether option A was good enough or whether option B, which was a much more intensive type of antiviral therapy, would be more effective in preventing mother-to-child transmission. And so this is an example of a study. I'll just tell you this part right now, where before the study wasn't even barely halfway through when the World Health Organization said everybody should be on option B. So we took too long. And you can see also down here, there's a very large sample size. So we're talking about, because this was 2/3 of the pregnant women in Dar es Salaam, that we were talking about something like almost 200,000 pregnancies. So in the end, we were able to find a significant benefit for the enhanced community health worker intervention to increase the likelihood that women would get 4 or more ANC visits during their pregnancy, about a 40% increase. And it's increased the total number of visits by about 8%, but wasn't able to get women in earlier. So it didn't succeed in that sense. But we also felt like, besides that conclusion, we thought that additional interventions would be needed to address this issue about increasing the timing so that women would get in at least once in their first trimester. And then finally, this whole study was embedded within the health system. And the way we collected data was in many countries in sub-Saharan Africa, there are these handwritten registers. They're like these big notebooks, where as people come in, it's recorded like, there's columns and the woman's name and then the date, and she usually has some kind of ID or medical record number, and then certain data are recorded. And then once one book is filled up, we just start with a new book. So what we did was we had data entry people come in at night when the clinic's closed, and they just typed in all the data that was in the book, and we had like a software where it looked just like the book. So that's how we got the data right from the system. But there was no researchers in the facilities. We were really just watching after the intervention was implemented or not. And so we felt like, because we got these good results, that it showed that we could do this kind of research at a very large scale, embedded within the health system in a low-income, resource-limited setting. Okay, so now step wedge designs, and I can get back to the question. So this is a schematic of a step wedge trial, and they tend to be, so I have step wedge cluster randomized trial. It really doesn't have to be cluster randomized, but in my experience, they almost always are, or even in my personal experience, they always are. And so what we have in the rows are, this could be one cluster or several clusters. And then in the columns, what we have are the time steps. And so what happens is what we randomize at the beginning of the study is when each facility starts the intervention. And we prefer to do that in a balanced way because it has nice statistical properties so that it looks like this. And, half the square is intervention, half is control. You don't have to do that, but you have the most efficiency. That's what the kind of balance that's generally good in a step wedge trial. And so what we see is we usually have baseline measures for all the clusters and all the individuals within the clusters. And then at the end, all of the clusters get the intervention. So is this experimental or quasi-experimental? So at these times, here, 2, 3, 4, and 5, those are purely randomized contrasts, because it's been randomized whether the facilities were in the intervention group or the control group at each one of those 4 times. But We also have the quasi-experimental piece, which is you can estimate an intervention effect with one facility in a before-after manner. So we can compare the outcomes in at time 1 for, say, this cluster 1. And then, I don't know why my arrow isn't showing. Oh, there it is. Okay, the outcomes in times 2 through 5, an estimated intervention effect. That's a before-after design. So that's quasi-experimental. And so that the answer to the question is both. For this reason, now some people say, oh, you should ignore all the within cluster comparisons and only look at the between cluster comparisons. So then you would throw away all the data at the beginning and at the end. Almost nobody does that, but it could be like a secondary sensitivity analysis. So you're only using the between, you'll lose a lot of power. You get a lot of power from those within cluster comparisons. But it could be of interest to compare those, make sure we're getting reasonably similar results and so forth. So that's kind of the overall idea for step wedge design. They're very, very popular in implementation research. So I'm involved in a lot of collaborative work, and everybody who comes to us wants to do a step wedge design. I'll talk a little bit shortly about the advantages and disadvantages. But here's an example of a study I worked on, early access to ART in Swaziland. It's now called Eswatini. This was funded by the Clinton Health Access Initiative. And it was comparing the impact of early initiation on ART versus the standard of care of initiation on ART on the patients themselves. So some of you might know, if you follow the HIV/AIDS research field at all, that it had been shown that getting people who test positive on ART right away reduced their infectiousness down to practically 0. And so it was, I thought of a way of ending the AIDS epidemic was to get everybody on ART, and then we wouldn't have any spreading of the disease. Whereas previously, from a purely the patient-focused perspective, the interest was in preserving the health and prolonging the life of the HIV infected themselves. And it wasn't clear that early access, early initiation was useful to the patients themselves. And it might be better just wait until their CD4s drop to a certain point, and then they go on ART. So that had already been established as policy by the World Health Organization. And so the question was, what is the impact of this early access on the HIV positive patients themselves? Nobody had really looked at that. And it could have different kinds of positive and negative benefits that were unknown, including it could keep them healthier longer. That would be the good thing. But then maybe it could increase their resistance to ART so that when they really needed it, it wouldn't be working anymore, especially if they weren't able to maintain good adherence over such a long period of time. And then there could be side effects for taking it for so long. So there was a lot of interest in this, and this step wedge design was rolled out, and it was conducted in 14 facilities in Eswatini. So each one of these rows is 2 facilities. Unlike the schematic I showed you where you couldn't really tell. And then you can see the steps were like 4 months, and we had the baseline, and everybody was, all the facilities had crossed over to early access by here. And then the blue is a transition period, which often comes up in the design of step wedge studies, because as I mentioned, these interventions are complex. And it takes a little time to get a facility on board, get all the equipment in, the drugs, train everybody, sensitize the patients, and so forth. And so we usually have these transition periods, which for statistical sample size calculations, technically you should take those out and you wouldn't count those times and any events that occurred in those times in your sample size and power calculations. So anyway, this is what it looked like. And this is a paper, this was the protocol paper down here about it. And and I should say one other thing again, because I want to emphasize how important RAPID is, because the same thing happened around here. World Health Organization decided everybody, as soon as somebody tests positive, they should be initiated to ART. And so there was no more withholding until somebody dropped to whatever the national standard was. everybody had to go on. And so that was the answer to the question. It was made without, say, a study that was designed to try to inform that question. Yes, I would like to continue to work on getting more rapid results, make our research more relevant. But we did find that early access increased retention by around 60%, and also much more dramatically increased retention and viral suppression. This is on the clients themselves, the HIV positive clients themselves. There was a lot of missing viral loads when we identified gaps in the system that needed to be remedied. But all in all, we felt like it was a successful study. So in terms of benefits and then cautions with step wedge designs, they're useful when as they're in implementation research and even potentially in effectiveness research, when there's already some body of evidence showing that this intervention should work. Because then the question is, from an ethical point of view, how can you withhold it from anyone? So on the other hand, how can we estimate effectiveness or study implementation without some kind of control? So what seems to satisfy a lot of decision makers, on the ground when we're trying to do these studies is the fact that there is, at the end, all of the facilities will be in the intervention group. So that might not be all the individuals, but all the facilities will have access to this evidence-based intervention at the end. Now, if it turns out to be ineffective, what does that really mean? But it's more encouraging and makes the whole exercise more palatable. So that's one aspect of it. And then as opposed to a cluster randomized trial where you're literally withholding the intervention from half of the study population for the entire time, like that's really hard to sell in kind of public health settings where we're talking about evidence-based interventions. So the other is it's good for studying service delivery or policy changes that do not need individual level participant consent, because some of these interventions, they're not even acting on the intervention. We're training providers. We're changing the way the system is structured. And so it's been argued that we don't need individual consent in this setting. And I could give a whole other talk about ethics and implementation studies. And then finally, so some of you may know that when we have cluster designs, the clusters aren't random clusters usually. They're clusters of individuals that have things in common, like they go to the same therapist, they go to the same doctor, they go to the same hospital. And because of those commonalities, they tend to have outcome rates. Their baseline outcomes are similar within their group than across to other groups. So that's measured by the intra-cluster correlation or the in-cluster correlation coefficient. And that quantity has a very big impact on sample size calculations. And the bigger it is, the more similar people are within a cluster, the less power you have, or the more clusters and individuals within cluster you need in order to have adequate power for a study. But with the step wedge design, it's another advantage of, because we're using these within cluster comparisons, then that's all subtracted out for the within cluster comparisons. It's not vulnerable to the loss in power from a high ICC, only the between cluster comparisons are. So oftentimes if you compare holding everything constant and you compare the power of the optimal parallel cluster randomized trial to the step wedge design, you're often going to get the step wedge design being more powerful, yet another advantage. Although I say often and not always, it might give you a good reason why it should be always, but the reason it's not always is because in the step wedge design, time is correlated with the intervention and actually correlated pretty high because of that design. So as time goes on, more and more clusters and individuals are getting the intervention. So that's a high correlation. You can actually calculate, there's a closed form expression for it. And so if there's a time effect, we have confounding by time, and that it has to be controlled for, and then you lose power. Whereas in parallel randomized design, because the two groups are running at the same time, You don't have time as a confounder. It's canceled out. So that's why step wedge designs are not always more powerful than parallel randomized designs. If you have a strong time effect, you might find the parallel design is more powerful, despite the ICC. So what if we can't randomize? And I'll talk now about some different types of studies that can be handled. We have the quasi-experimental and then the observational. So the observational, I think I'm not going to talk about it. How am I doing on time?
It's 1:43.
Okay, so I don't have a lot of time. So we have very strong epi department here. It talks all about observational case control and cohort studies and causal inference methods used to obtain causal estimates when the intervention, treatment, exposure is not randomized but chosen by the study participants. So I'm going to just skip all of that and as well as an example. And I think I'll even skip quasi-experimental designs. I mentioned them, even the pre-post aspect of a step wedge design. I did have an example of the interrupted time series design that I worked on. Maybe I can just say very quickly, it's very good for policy changes or even changes, let's say if you're, it could be policy at like the government level, or it could be policy like a hospital is doing one thing and then they switch and start doing things differently. And they want to know, did that switch improve things or make things worse? So you have whatever the outcome rates are before that change is made. And then the assumption is that after the change is made, that if it hadn't been made, that's the counterfactual, you would have seen the same rates. And so it's nice, you can have controlled interrupted time series where you have another group that the change wasn't made to at all, and you can try to estimate the time effect just because that's the flaw, like sort of the flaw in terms of extracting from the causal validity of an interrupted time series is we have to assume there's no time effect. But then when the intervention happens, there might be a jump. And if we're trying to prevent something, the rates might drop down. And then it might have the same slope, or we can start to see that even after that, things get better at a slower rate. And so we no longer have this flat slope, but we have the slope going down. And so these things can be estimated using like segmented regression methods and things like that. You can do these kinds of studies from medical records and other publicly available records. So I think it's a very useful design. And we looked at it in terms of the impact we use the method to look at the impact of the Affordable Care Act on colorectal cancer incidence and mortality in the Kaiser Permanente health system in Northern California, where the Affordable Care Act, which is still in existence today, provides free colorectal cancer screening or colonoscopy, which is an evidence-based intervention that's been shown in highly controlled trials to reduce colorectal cancer incidence and mortality by at least 50%, but hadn't been taken up in the general population because it costs about $3,000 a screen, and most insurance didn't cover it before the Affordable Care Act. So then we want to say, okay, the Affordable Care Act comes in. Do we see any impact on screening? And actually, this is just the graph. It's, it was kind of shocking to us because it was like textbook. And you can see this is colorectal cancer incidence, but it looks very similar for mortality. And this is with, over 1 million people in Kaiser Permanente from the electronic health records. And we see basically a flat or even slightly increasing curve before the ACA came in. And then the the Affordable Care Act came in, and then we see the drop, just like that schematic picture. And then we see a slope going down. It was just kind of amazing. So that shows how that can be used to evaluate a policy. And then I'll just maybe briefly touch on a couple of innovative designs that are popular in implementation science. So I mentioned SMART, and I think the best thing to do to learn about SMART would be to invite Susan Murphy to come and give a talk about SMART. And for, for patient care, say even in oncology, I don't know if it's being used, but it could be very useful because what it does is it figures out a dynamic treatment regimen where you start everybody on the standard protocol, and then some people respond, so they're fine, but then other people aren't, and then new things are added. And that can be done in a randomized way so that you have at the end, like a cookbook, like, you know, people who you give the standard thing to, and if they're fine, keep them. But for those people who, whatever, their tumor grows more than 1/4 of a centimeter, then you add this. And then you follow them for a certain amount of time. And then if something else happens, then you add that. And instead of, say, doctors, I don't know, maybe they have protocols, but they're probably not, these complex dynamic treatment regimens are probably in most cases not based on good empirical data. This is a way to get the good empirical data to figure out these kinds of things. So I'll just go on to MOST. Where it's MOST is an acronym for the multi-phase optimization strategy. And so what that adds on is we have over here the standard evaluation of a complex multi-component, multi-level implementation package. And then how do we come up with this package? So what's usually done is, you know, we use sort of clinical and, you know, expert knowledge to come up with this package. But these packages are too complicated, and the expert knowledge is probably in many cases far from what the optimal combination could or should be. So this is a beginning of trying to get at using data and empirical methods rather than just sort of subjective methods or group consensus to come up with the package. And first, there's the preparation phase, which I mentioned. Another role of social scientists is that's basically done qualitatively, where patients and providers and all the stakeholders at the different levels are interviewed using rigorous social science methods, key informant interviews, focus groups, observations, and so forth. And then that data is analyzed using their systematic methods to come up with suggestions for what kinds of strategies might facilitate the uptake, fidelity, and sustainment of the intervention, as well as what the barriers have been, and then how to maybe address them. And then after that qualitative phase is done, then a short, it's advised that a short 2x2, or not 2x2, but it would be like capital P by capital P factorial study is run with a very short-term endpoint to try to rule out all of these, from all of these possible ideas, which ones are showing the most promise and at what dose. And then from there, a package is put together, and then a standard study is run. So that's the idea of MOST. And then, so this is, as I mentioned, there's like a method for figuring out how pragmatic a study is. This is to just let people know in terms of all the components and how they're adapted, because what happens is these packages aren't optimal. And then what's happening in real life is the researchers are just adapting the package, you know, on an ad hoc basis, using subjective information of different kinds. So this is a suggestion for at least to begin to try to deal with rigor in evaluating an intervention in the face of adaptation. At first, we need data about what's being adapted, when, and why. And this is a framework for doing that. But to go a little further, and I'll probably have to end after talking about this, is the Learn As You Go design, which is something that I've been working on now for maybe the past 6 or 7 years with Judith Locke, who some of you might know. She was also in the biostat department here. She's now at BU, and Daniel Nevo, who was a postdoc with us when we were here, who's now at Tel Aviv University in Israel. And we've published one paper on this. We have another one archived here with a PhD student, Judith. And so the idea is with the Lago that we have a multiple component intervention. We start out with our best guess at what that intervention package should look like. We have pre-specified stages. We're now at a point where we're actually working with real life studies in real time. Nobody seems to be able to handle more than 2 stages over, say, a 2.5 or 3 year study period. So we have maybe 1 or 2 optimization stages. We get to the stage, we analyze all the data, the outcome data, as well as the intervention data. And then we suggest an intervention package to use in the next stage that's going to be the most cost effective based on the data we have. And then that continues on to the next stage. Then we analyze all the data again, and then we recommend the most cost-effective package to use for the next stage, and so on. And like I said, we're usually so far only able to do this 1 or 2 times. And then we end up with ideally a effective intervention package, a equation with estimates that can suggest for other types of situations what the optimal package could be. We will also get estimates of the individual component effects as well as an overall intervention effect. And when we're optimizing, we're always trying to at least reach a certain power at a certain point, or even exceed that power at the same time. So that's the design. And, this is maybe a formal, more mathematical way to explain what I just said in words that I think maybe I can skip. But unless I see everyone's looking at it, it might be better to continue. And I mentioned what the outputs were: the strategy, the impact of the individual components, the test of the null of no overall effect of the package, and estimation and inference to the extent that the goal was achieved, say 80% hypertension control, and so forth. And so then the big mathematical question is, since we're analyzing the data multiple times, including the outcome data, and the outcome data is being used to determine the optimal intervention package for the next stage, do we still have a valid type 1 error rate of a hypothesis test of no overall intervention effect? And it turns out that given sufficient data at each stage, and assuming that the data from previous stages affect the choice of the intervention package, but given the current intervention package, the outcome at the current intervention stage is independent of the past data that we, including past outcome data, that will still have a valid test of the null hypothesis. And so that was proven in this Annals paper. And so it's kind of like a major breakthrough for implementation science, because it's so hard to come up with these complex packages a priori. And now we're working on all different extensions to this for clustered data and repeated measures data and continuous data and stepped wedge designs and hybrid type 2 designs, which is the next thing. How much time do I have now?
You 2 or 3 minutes.
Okay, so the last topic, hybrid design. So also another important design and implementation research, and that's basically from a statistical point of view, it means that you have 2 co-primary endpoints. A clinical endpoint and an implementation endpoint. Because pure implementation studies, like let's say the Familia Salama I was talking about, the endpoint was just, did a woman have 4 or more A&C visits? Nothing about what the outcome of her pregnancy was. It's like, we already know that if she has 4 or more A&C visits, she's going to have a better pregnancy outcome. So we're not even measuring the health outcomes anymore. You can actually get major funding from the NIH with studies with no health outcomes or clinical outcomes being measured at all in the context of evidence-based interventions. So a hybrid design kind of is the best of both worlds, because we have the implementation outcome, but we're also looking at a clinical outcome, a key clinical outcome. And I think that's important because we can be doing studies, say in Tanzania, and then let's say we go to, some part of India, in Uttar Pradesh, and maybe this intervention doesn't work there for all different cultural and contextual reasons. So it's good to make sure that we're still getting the clinical benefit as we're focusing on the implementation aspect. So we have 2 co-primary outcomes. And that you might think, well, that's boring, because like in genomics, we have high dimensional data with many, millions of outcomes. So 2, that's nothing. just use bumferoni. So that's certainly an option. We have to correct for the fact that we have two co-primary outcomes, and there's already a multiple comparisons problem. But then there's also this interesting issue that there's really two hypotheses here. There's what's called the disjunctive hypotheses, which would reject the overall joint null if there was an effect on either of the two co-primary endpoints. And then there is what's called the conjunctive hypothesis, which rejects the null only when we have an effect on both. So which one are we actually interested in here? So, I think actually we're interested in the conjunctive, because why would we be doing a hybrid type 2 design with two primary endpoints and then say we're going to feel like we have a successful study only if we reject the null on one of them? But it turns out that all these different options for testing are really focusing on the disjunctive hypothesis. And we have the p-value adjustment methods. And along with bumferoni, there's two others. We have the combined endpoint approach where you take the two outcomes and you sum them is one way. That's been very popular in clinical research. Or you can take you can create a weighted test statistic of the z-scores for each one. So these kind of approaches have been around for ages, but believe it or not, they've never been adapted to clustered studies. So we did some methodologic work to extend these combined outcome methods to apply and give valid type 1 error rates when we have clustering. And then there are multivariate statistical approaches like a linear 2-degree of freedom, conjunctive, and disjunctive hypothesis test. So now we have 7 approaches, and which one is better? So, and we want them all to have the right type 1 error rate, but then there could be finite sample issues with clustering. It's well known that the size of hypothesis tests can be distorted in clustered data when you have a small number of clusters. Finite sample properties of these 7 options could be very different. And then the power, which one is more powerful? So that's something else we're looking at with a PhD student that I have who has joined our center at Yale, a Biostat PhD student. So anyway, here's, I'm kind of at my end now. So our conclusions are implementation studies require consideration of context, multiple levels, multiple components, timing matters. We have a lot of study design options. We can identify and rank them in terms of their appropriateness, power, causal rigor for our purposes, and then decide. We can consider randomization, real world rollouts when it's possible, but for the various issues I mentioned, it may often not be. We can consider innovative approaches if they're relevant to the study. And I find in my collaborations with implementation researchers, they are not necessarily very well schooled in quantitative methods at all, but they're very interested and open to using advanced methodologies, especially if you can explain them intuitively, and that they have their peer-reviewed publications, so that we're not just making stuff up and whatever. And then if randomization isn't possible, there are quasi-experimental and observation designs available, and then causal inference methods can come into play. And then, as I've kind of touched upon, and there's still many more, but there are many interesting methodologic questions that are unsolved. So thank you. And that's what I have to say about implementation science today.
Excellent presentation. Lot to learn. I just want to follow up on your last point where you mentioned that there is some hesitation for, among colleagues for innovative clinical design methods, like LAGO or SMART compared to the conventional method. So do you think same hesitation or preference also present in NIH or FDA when they review such clinical trials?
Yeah, I mean, so FDA has not really considered LAGO at all. NIH, we're working with 3 studies that are ongoing where LAGO is part of their accepted protocols, and NIH is funding us in a supplement to work with these studies to implement LAGO. So that's just a very beginning. But I do think that there's a lot of interest in NIH for LAGO because everybody knows about all of these failed trials. There's just been so many of them. So we feel like this is a way to possibly save a trial. Like even, I didn't have time, but our example was the Better Birth Study that was led by Atul Gawande. It was, I think, a $300 million study that involved uptake of the safe childbirth checklist to reduce maternal mortality in India. It was a failure, even though every one of the items on the safe childbirth checklist are evidence-based interventions, at least from an efficacy point of view. And I know statisticians who were on the DSMB, and they said it was heartbreaking to sit there and they could see fairly early on, this isn't going to work. And they couldn't say anything, and they had to just let the whole thing go. And then, it was published in the New England Journal of Medicine as a negative study. They couldn't do anything to change their protocol to increase uptake, figure out what was wrong, and try to fix it and all of that. Yes.
Great talk, by the way. But
Thank
the parts that you were referencing, like when the WHO would make their own policy decision before you got to the end. Is there, like, to what extent are there like ongoing discussions with them throughout, where it's like, do they have an understanding of like, we expect this huge study to be finished by a certain time? Are they asking questions about like what the timeline might be so that they might like wait for it, or is it often just like, no, we feel like we have enough info, we're going to pull the trigger?
Well, they know about these studies.
Yeah.
There's the other example is there were 4 HIV prevention trials running in sub-Saharan Africa, including the Botswana study that was also led by Victor Di Gratola and Max Essex here at the Harvard School of Public Health. And then there was SEARCH, and there was 2 others, I think it involved maybe over 1 million people to see whether a combined early access to ART, male circumcision, community-based screening and testing, and PMTCT, all of it, like throw everything at it, would it like lower HIV incidence rates significantly in these different large parts of different countries in Africa? Again, all of the studies by Botswana were negative, even though these were all evidence-based interventions. And before these studies were finished, WHO just mandated that all these things should be done.
Yeah.
So we have negative studies, but efficacy, the efficacy of all of the different elements is totally there. And then there's a lot of political pressure about double standards and so forth. So they feel like they just have to go ahead.
Yeah, so they feel like they already know enough about the efficacy.
But they knew enough about the efficacy before we even started the studies.
Yeah.
Because we're doing effectiveness studies on efficacious interventions.
Sometimes there's just impatience at a certain point, I guess.
Well, political pressure.
Yeah, for reasons, yeah.
And then, the drug companies come in too. And so they're very eager to get the whole world on ART.
Yeah. Really fascinating.
And to get everybody taking cholesterol lowering drugs. And so, they want to just get moving on this stuff.
Yeah.
Yes.
When, you talked about those 3 R's, one of them was trying to be more rapid. Do you think there's any particular elements that could really help with making things more rapid? Or is it kind of across the board to make things faster?
Yeah. So, I've thought about it some, but not a lot. And I'd love to hear other people's ideas. But I have thought, well, of course, we can always increase the sample sizes and then decrease the duration. And even maybe in some cases, maybe that's even cheaper. Like I've never been involved in designing a study where that was an element that was being considered. So that's one thing that could be looked at. And another is using electronic health records and probably using observational data more, and then causal inference methods, rather than running these more complicated, clunky, randomized trials. So those are 2 ideas I have. Oh, I think you had.
Thank you. I'm not in this role, but the talk is kind of attractive. I'm doing something related to learning and microsoft, so that sounds quite general. So So you mentioned that it was hybrid design. And it's a critical one, and if you take,
Yes.
yeah, so I wouldn't know, you just put a 50-50, or which one is much more important, or you just you change the ratio
Mhm.
and the different scenarios. That's my question.
So when I've seen it, first of all, it's all being done in a very ad hoc way right now in implementation science. Like you see things like people will publish, to the extent these are even published, they'll publish the clinical outcome in one journal and then the implementation outcome in another journal, and not even mention that there were actually two primary outcomes and do any adjustment. But the question of the relative importance, like say if you were using the Bonferroni method, you don't have to use 0.025 for both outcomes. You could say, we're going to reject the null at 0.04 for this outcome, which is more important, and then 0.01 for the one that's less important. As long as you do that in advance, that's still a valid testing procedure. But I've never seen anybody do that. And there might be ways to adapt some of these other methods to take into account the importance. But I haven't seen it done, nor have I seen it considered. And then I think you in the very back.
Just on a broad level, I didn't understand what you said in the beginning when you said scale out, and whether that's connected to the, indications that are approved in effectiveness. Says implementation research scale out.
So, a lot of people talk about scaling interventions. So we do a study, even an effectiveness study, let's say the one I showed you, Familia Salama, that involved 200,000 pregnancies. So then fully scaling it up would mean scaling it up to all of Dar es Salaam, not just those two districts, but even the third district, and continuing it. So that would be scale up. Scale out would be start doing it in Johannesburg, South Africa, in a different context. And then what is scalable up and what might have to be adapted could be different from what is scalable out and what has to be adapted. And then I think somebody else maybe have their hand or no?
We have 3 questions from the online audience.
Okay.
The first one is, could a step wedge design be used to study efficacy and safety of an intervention or drug? Why or why not?
Well, it seems the standard for efficacy trials are individually randomized trials. I'm not sure I've seen any examples of step wedge for efficacy. Theoretically, it could be done. And I don't know, I've just really never thought about it because it's just like never considered. But maybe it would be a good thing to do, especially I guess if you have these, well, first of all, the step wedge design, as I mentioned, is good if you have clustering. It improves your power if you don't have a strong time effect. So you don't have a clustering issue with individually randomized trials. So then that sort of that advantage. And if you're doing efficacy research, you really don't know if it's not an evidence-based intervention. So the advantage of saying, well, everybody's going to get this at the end may not be a big sell. Although lots of times, maybe I know a lot of studies, even efficacy trials have trouble recruiting patients. And maybe a step wedge design could be more attractive to patients. Well, you might be randomized to the control group and get standard of care, but if you hang in there until the end of the study, we're going to give you the new intervention. So maybe that would be a way to improve patient recruitment. So I guess I'm just thinking out loud about possible advantages and disadvantages.
Probably depends on the intervention as
Yeah.
well, how. So next question is, could you please comment about the biases and internal validities of findings emanating from the step wedge design versus parallel cluster or CT design when it comes to accounting for differential calendar time of exposure to intervention in different clusters?
Yes, thank you. So yes, as I mentioned, a well-conducted cluster randomized trial, parallel cluster randomized trial completely controls for the time effects by design without any need for any modeling, because it should be balanced with respect to time because they're running in parallel, just like it should be on average balanced with respect to, say, the distribution of women or race, ethnicity, or socioeconomic status or anything else. So that's a strong advantage of a parallel cluster randomized trial. In a step wedge design, you must control for, or not must, but almost all studies are powered to control for time, at least for the time steps. So we're controlling for confounding using sort of observational methods by putting time in the model. And usually as an indicator variable, so we're not saying it's linear or it has any kind of form, but within, say, the 4-month steps, there's just an indicator variable for time. And then you can, on top of that, model time and put even to control for even what we call in epidemiology residual confounding, where within a time step, there could still be time effects within the time step if there's a very strong time effect. But in my opinion, time is overrated as a problem because these studies are only like usually at most 3 years duration, because we all know the NIH timeline is 5 years. Takes a year to get your study going, and then like a year to analyze the data, wrap it up and all of that. So there's usually no more than 3 years of follow-up. What kind of time effects can there be in over 3 years? You know, unless there's some major medical breakthrough or something and certain people are switched to it at a certain time, or, I mean, it's not impossible, but it's not like, say, in the Nurses' Health Study where we're following women since 1976 for 40 and 50 years. Well, yeah, there are some calendar time effects, not much actually, but some. But in these short-term step wedge designs, I think time is overrated. We're actually doing research because you lose a lot of power by controlling for time in a step wedge design. And you get very little reduction of bias, almost always, because there's very small time effects. So thinking about some ways of thinking about some other analytic methods that exploit the lack of a time effect to gain the power back.
So the last question is, would the optimal best analysis strategy of data emanating from a stepped wedge design require removal of outcome data collected during the preparatory intervention rollout phase?
Well, if you're a hardcore randomnista, the answer is yes. You would delete the baseline period, and you would delete the last period where everybody's on the intervention. And then you would have a fully random, all your data would be fully randomized. So some people have made the argument that that's what should be done, but in reality, I've never seen it done. Everybody uses all the data.
I think we're done with the questions from the side as well. Thank you.
Thank you so
Great.
much.